All right, I think we should get started. I'm Nabil Sumrani, and I would like to welcome you back to our next session. We have three outstanding presentations by three outstanding speakers. To start, Dr. Michelle Josephson is no stranger to Downstate. In fact, she's an honorary faculty member of Downstate. All right, and she'll be talking today about how to individualize and optimize transplant outcome, okay?
Thank you. It's a pleasure to be here, and I'd like to thank Dr. Sumrani. I'd like to thank Dr. Tedla and the rest of the organizing committee for inviting me to talk. So, as Dr. Sumrani said, I'm going to be talking today about individualizing immunosuppression. And in a way, this is a very timely topic, and that's one of the reasons I'm very excited to talk to you about it. In 2015, President Obama at the time, in his 2015 State of the Union address, announced that he was launching the Precision Medicine Initiative. And this was a bold new research effort to revolutionize how we improve health and treat disease. So and you may be saying, well, what is precision medicine? And precision medicine is defined by the NIH as follows, and it's an approach which takes into account individual variability in entities such as genes, environment, and lifestyle for each person. And with this initiative, you may say, well, what's the mission? Why are we doing this? And the mission is really and the goal is to give us a whole new era of medicine, harnessing the power of research, technology, policies, and to enable and empower patients, researchers, providers, to work towards the development of individualized care. So I think the next important question with this in mind is then to ask, why should we individualize transplant care? And there are really a lot of good reasons why we should individualize transplant care. First of all, we really want to reduce the over-immunosuppression that we see a lot in patients that we don't realize are at low risk, but who are at low risk for rejection, but also may have high risk for rates of infectious problems. For those who are on the opposite side of the spectrum, individuals who may be at high risk for rejection, we certainly want to prompt an intervention early so that we can address those issues. And the overarching goals of these approaches are to reduce patient morbidity and certainly to improve long-term outcomes, because as we know, we've done a lot for the short-term outcomes, but in many ways, we've reached a plateau for long-term outcomes. So with this in mind, I think it's reasonable to next ask, so we're in this current era of precision medicine, do we actually individualize care? And I could tell you my answer or my opinion, but I decided to reach out to some others. So I contacted former fellows that I had worked with, and I asked them a series of questions. But let's just focus on the top question, the first question. Do you think that we currently individualize immunosuppression? And if yes, how? So do we individualize immunosuppression? Well, as you could see by the answer, really the overwhelming answer is we try, but not exactly, or no. Only one gutsy person said, yes, we do. But most of us believe that no, we really don't. And so but it also, I think the answer says something else. It says that we aspire to this. This is something that we haven't really achieved yet, but something that we want to do. So, how do we currently try? What are we doing to individualize care or immunosuppression? So, what we usually do is we modify immunosuppression based on recipient issues. So we have this sense, we sort of perceive what the patient's immunologic risk is. For example, we look at their age. If they are old, we may say, their immune system, it's just not going to be as robust. If they're very young, we may say, oh, this is someone who we think is going to have, may have a very virulent or vibrant immune system. Depending on their HLA matching, we may worry about how we should immunosuppress them. So if they're a 6-antigen match, we say, oh, we can get away with less. If they're not, we may be more concerned about rejection. They have a high PRA, panel of reactive antibodies. We may say, well, this is someone that's had some sensitization before. Maybe they're going to easily form antibodies. With prior transplants, we may say the same thing. If they have a self-declared race of African American, we may say, they're at more risk for rejection. We have to concern ourselves with that. If they have or have developed donor-specific antibodies, that also gives us pause because we think, they're at higher risk for antibody-mediated rejection. Maybe we should intensify their regimen. Or if they've already had a history of rejection, say, we didn't use enough immunosuppression. We need to use more. If their CNI troughs are low, we adjust. If their CNI troughs are high, we adjust. And we come up with this idea of what's a high and low trough. We also have sort of a perceived risk of a patient's risk of post-transplant diabetes. And that may also change how we immunosuppress a patient. So someone who we say has a high risk of post-transplant diabetes, maybe we'll reduce their prednisone quicker than another patient. Or maybe we would even consider using cyclosporin instead of tacrolimus. So all of these perceptions really do drive us to change how we treat an individual patient. BK virus, we're going to hear from Dr. Didani later about, may also help us change. So if they had lost a prior kidney transplant to BK, well, in that case, we might reduce immunosuppression. If this is someone who we feel has, for example, had a typical HUS and we're worried that they may have recurrence, we may have them on eculizumab, or we may be very concerned about using calcineurin inhibitors in them. Someone who's had skin cancer, we may say, this individual, they're going to benefit from an mTOR inhibitor. I'm going to give them everolimus. I'm going to give them sirolimus. If a patient has diarrhea after transplant, we may say, we need to really reduce their calcineurin, their anti-metabolite, or maybe we need to put them on something else, or give them azathioprine, or even not give it to them. If we have them on antibiotics such as erythromycin, we're going to say that's going to interact with their enzyme system. We're going to preemptively lower their calcineurin inhibitor. Someone who we have on allopurinol, if they happen to be on azathioprine, we're going to, because of the drug-drug interaction and what it does to xanthine oxidase by paralyzing it and leading to increased levels of 6-MP, we're going to say we're really going to use a much lower dose of azathioprine, or depending on their insurance, that may force us to individualize care because we may or may not be able to use certain medications. For the donor, if there was a very long ischemic time, for example, we may say, well, this is someone who's at risk for a delayed graft function, and I'm going to use thymoglobulin for a longer period of time to start as an induction. Maybe I'll really put off or postpone introducing the calcineurin inhibitor. Similarly, with old kidneys, we may want to go lower on the calcineurin inhibitors, or if there's donor disease, we may adjust our immunosuppression regimen. So all of these issues really affect us and cause us to sort of change or modify for an individual. So if you sort of think about this in broad areas, you'd say, there's a perceived level of immunosuppression. If we perceive the patient's level of immunosuppression as being too much, that they're over-immunosuppressed, maybe because of an infection, they had BK or CMV, maybe because they had cancer, post-transplant lymphoproliferative disease, or maybe because their calcineurin inhibitors, we feel their trough is too high. that's going to have us, for that individual, reduce their immunosuppression. On the other hand, if they've had a rejection, if they have developed donor-specific antibodies, if their calcineurin inhibitor trough level is quite low, well then, maybe what we're going to do is increase their level. So those issues really do drive how we adjust immunosuppression. They've had drug intolerance, diarrhea, as I mentioned, for example. We may also either use different agents or adjust levels, and access. If they've access issues with respect to insurance coverage, that's certainly going to adjust what we do. Our strategies are pretty simple at this point. We alter our targets for CNI troughs. Maybe we're going to change doses of mycophenolate, or perhaps we'll use a different agent. We might use thymoglobulin in place of dicluzumab as an induction agent. We're worried about a high rejection risk. Belatacept, instead of a CNI, if we think that they're at risk for some calcineurin-induced problem in their kidney, that may end up prompting us. Patients who have diarrhea, sometimes we'll use azathioprine in lieu of mycophenolate, or if they can't tolerate it. And there are points where we'll substitute mTOR inhibitors for CNIs or antimetabolites. Those are all approaches towards individualization. But the truth is that all of these approaches, up until now, our approaches have been very much reactive. So if there's a problem, we may change. But if there's not a problem, we're really going to generally go with the standard approach. So we wait to see how the patient reacts, and then we modify, or how we perceive they're going to react, and then we modify. But I think we're really on the edge of a change with respect to our approach towards patient management. And what I'd like to do is kind of tell you about two different approaches that are really new approaches towards individualization. And the one I'm going to talk a little bit about how we may individualize based on genotyping, and the other I'm going to talk to you, in the second part I'm going to talk to you a little bit about how we may individualize based on new tests that will give us an ability to monitor patients better. So let's first turn our attention to the issue of genotyping and what we might be able to do. So let me give you a little background about why we're going to do this. So let's think about metabolism of drugs. So what about tacrolimus? We may remember that tacrolimus is metabolized by demethylation and hydroxylation that occurs in the gut, in the intestines, as well as in the liver. Now, individuals have, and it's metabolized primarily by the CYP3A5 system, or CYP3A. But CYP3A5 comes in sort of different flavors or different variations. We have CYP3A1 and CYP3A5-3. Now, depending on whether you are you have CYP3A11, 13, or 33, that is going to change how quickly you metabolize tacrolimus. And so it turns out that some of the dosing that we use, that we sort of, it's really a trial and error approach. At the beginning of transplant, we're trying to figure out what's the right dose for a patient. But some of that, a lot of that is based on what the patient's genotyping is. Now, what about other drugs? Well, we have other information for azathioprine. I mentioned that azathioprine is metabolized, at least in part, by xanthine oxidase, but it's also metabolized by thiopurine methyltransferase, and that takes 6-MP and as you can see over here on your left, and metabolizes it to an inactive 6-methyl mercaptopurine. So I know we don't use azathioprine so much, but we do still use it a bit. And it turns out that TMPT, or thiopurine methyltransferase, also comes in different varieties. The vast majority of us have the wild type, actually up to 97% of us have wild type, but about 3 to 14% of us are heterozygous for the wild type and the variant, and a very, very small number of us, percentage of us, have actually are homozygous the wild type and for the variant. And depending on how much of the variant you have, you may have a much less or decreased amount of metabolism of 6-MP, and so you can have a tremendous amount of 6-MP sitting in your system, and you can be very much at risk for moderate to very severe myelosuppression. And so, again, we might opt not to use that drug or to use extraordinarily low doses of it if we knew that up front. So this issue of genotyping and how we might use it in medicine has become a big deal. And there's a group of centers across the country that have a study called IGNITE. And they're not just looking at transplant, and they're not just looking at drug metabolism. They're looking at a number of things. But when in the area that we're concerned about, there's at least one center, maybe more, but one center that is doing some work. But this IGNITE program is a consortium that is doing demonstration projects that looks to say, can we incorporate genomic information into the electronic medical record and then allow providers, give them to make decisions based on this information. And so with regards to our interest, with regards to transplant, this falls within a project that's going on in Indiana. They're doing a project called, kind of a cute name, Ingenious. Genius name, I guess, is the Indiana Genomic Implementation and Opportunity for the Underserved. And what they're doing is they're looking to see whether incorporating pharmacogenetic testing information into the medical record will both improve outcome for the patient, and they follow the patient for a year, so it's 1 year outcome, and also decrease the cost of care. And so there's a segment or a part of this study that actually does speak to transplant patients. And what they're doing is they're identifying anyone who's getting a new prescription for tacrolimus or azathioprine, and they're eligible to enroll in the study. And the patients are then randomized to either get pharmacogenetic testing or not, or just standard of care. And then for the study group, those that got the testing, providers, so the information is put into the medical record, providers are given information about their genetic testing, and they're also given suggestions about how to dose the medication. The providers can do whatever they want. They can decide yes to use it or not to use it. And so at the end of the year, they're going to then look to see whether or not the patients had a better outcome than the control group who just had standard of care without the testing, or whether or not they also had a lower cost of care. So that's kind of a really exciting study that's on the horizon. So really, in many ways, that is how we have been managing our patients post-transplant. We just don't have a tremendous amount of tools or biomarkers to help us to know where we're heading. I think everyone in this room would agree that we need better immunomarkers or better biomarkers, accurate biomarkers to know what we should do. So what would be a good biomarker? Well, a good biomarker would be one that was reliable, accurate, inexpensive. That probably won't happen, but that would be nice. Non-invasive. Certainly we need a biomarker that's sensitive so that we are able to detect developing injury and predict it, as well as one that's specific so that we can distinguish what are the type of injuries that's occurring. Now let's take a look at what we're currently using. And I would challenge anyone in this room to argue that any of these that we're using are sensitive or specific. And you might somewhat say, well, kidney biopsies, those are pretty good. Okay, fair enough, but they're certainly not non-invasive. So I think, these are not ideal biomarkers by any stretch of the imagination. But this is what we have. This is what we have to work with. There's no question that we need to be able to predict better what is coming down the pike. And fortunately, there are a lot of emerging tools that are coming out there. I just want to talk to you a little bit about what we're going to be seeing in the near future. So actually just recently FDA approved is the AlloSure assay, which is a donor-derived cell-free DNA assay. I think it's kind of an interesting idea. It's this idea that, that actually all cells are going to release some fragmented or damaged DNA, and that we can distinguish that DNA, the recipient DNA, from the donor DNA. So you can sort of see what a baseline is of release, and that tells you that the kidney is going along stably. But if you start to see an increase in that level of donor DNA, that tells you that there's a problem in that kidney, that there's more cell breakdown, and tells you early, so then you may be more aware and realizing that maybe rejection is just about to start. Another test that is not out yet, but that's interesting, is it falls into, I guess, the proteomics regimen, and that is a cell that looks at the chemoattractant chemokine urine CXCL9. Now, there are other tests that looked at urine CXCL10, sort of talk that briefly in a minute, but urine CXCL9 in and of itself has been shown to diagnostically correlate with T-cell rejection, and it's apparently also quite informative when a rejection is being treated, whether or not it's being effectively treated. And it's kind of an exciting one too. Perhaps an even more exciting thing that's coming down the line is the urine 3 gene signature. Now, I should not be the person in this room talking about this. This should be Dr. Dedadier, whose group at Cornell is really piloting this whole entity. This is looking at urine to pick up a marker by quantitative PCR, a 3-gene marker, and by looking at, what they did is they did a whole series of tests where they started with looking at rejecting kidneys and grinding them up and seeing what were the genes expressed, and then looking to see what you could find in the urine and what was most predictive of rejection. They found a 3-gene marker of CD3 epsilon mRNA, CXCL10, and 18S RNA. And that when that was detectable, that happened before clinical recognition of rejection, and that it was very good at distinguishing acute cellular rejection from non-acute cellular rejection. So it was specific. There's also K-sort, another test that's out that comes from Minnie Sarwell's group. This is a 17-gene set that also predicts clinical rejection. It doesn't actually distinguish between antibody and cellular, but you can use it in combination with other tests to get a sense of that. There's also another test that's I don't think it's out yet, but called NDAT, that looks at altered expression of 173 gene transcripts that indicate alloantibody is acting on the microcirculation, giving you the sense that you have an early beginnings of an antibody-mediated rejection. This comes out of Phil Halloran's group. And then finally, the last one I'll just mention, it's not finally at all, because there's lots of other tests out there, but there's a GOCAR, which is an interesting test that was developed by Barbara Murphy at Mount Sinai and done in a multi-center group, where they identified 13 genes at 3 months that were able to predict that at a year you were going to have fibrosis in your kidney transplant. Now, it doesn't tell you how to treat and what to do, but it does identify individuals who are at risk for future kidney loss or early kidney loss. This is a very hot area, and I just don't even have time to go over everything, but there's also other tests. There's actually tests in the imaging arena, such as MRIs and PET CTs that they're looking at to try and give you early predictions of immunologic entities. So this is the whole omics areas. I told you a little bit about transcriptomics and proteomics, but there's also metabolomics. I mean, it's really an emerging area where we're going to be seeing lots and lots of tests come out, and some of these are going to do very well, probably, and some of them are going to just fall flat. They're not going to end up working out. But centers and companies are really developing new tests, and there's a lot of interest in this. And just want to mention one that's in my backyard, or sort of in my backyard. In the U.S., there's a company called Transplant Genomics Incorporated. This is an effort that's going on by a group. Well, it actually really started with Dan Solomon, who passed away relatively recently, but he was at Scripps, and he worked very closely with Mike Abakasis and the group at Northwestern, and they are looking again at sort of a gene expression profile in the blood to be able to differentiate between rejection and predict rejection. I spoke to John Friedewald, who's one of the nephrologists over there, to try to get a little information, and he told me he's very hopeful that they're going to be able to get coverage decision by the end of the year, maybe be able to release it. They're hoping to do a first-generation biomarker to be able to differentiate rejection from normal with negative predictive value in individuals who have some kidney dysfunction. And then what they're hoping to do is to come out with a second-generation marker, which will help distinguish subclinical rejection from normal. So very exciting time here in the U.S., but also very exciting time all over the world, because we're not the only site that's developing these markers. And I just looking around, I found actually this biomargin in Europe that's also looking at early markers. So I think our practices are going to start to change. What do we do now? Now we monitor for drug level, we look at renal function, we try to get a sense from our patients of whether they're adherent to medications or not. We screen for viral PCRs. That's what we have to work with. I think, as in the months, maybe years to come, we're going to have a whole host of new tests that either will just get rid of the tests we're currently using, or we'll use them in conjunction. But there's going to be a lot of new opportunity to really see what's going on with our patient and better individualize the medications and the care we provide based on what's really going on. Not so much guesswork anymore. But there's going to be a lot of challenges. Certainly there is the challenge of commercialization, and this is beyond the scope of anything I know about, but I imagine that this is going to be a huge problem. But even if we say everything's going to work out for commercialization, put that aside, there's going to be a lot of questions that remain. I think, just off the top of my head, I would think about, how are we going to really use these biomarkers in the real world of clinical care? How often will we use them? When should we use them on everyone? These are things that we really don't know. One of the things I think, we'll also want to know and we'll hope for is will biomarker-driven care decrease the need for biopsies? I'm sure we all hope that would be true. That would certainly make our patients happy. Will these tools limit infectious complications? Certainly, again, I hope, we don't know, but we hope that would be the case as well. We hope it would reduce the amount of post-transplant lymphoproliferative disorder we see, and the amount of rejections that we really see, or that we treat late, because we'll start to treat them just at the very start. Will these new approaches, will they, and I think the most important thing, and the thing we're hoping for, is that these new approaches will improve graft function and also improve graft survival. That's, at the end of the day, that's what's important. But also what's important, and I'm glad that Indiana is looking at this issue, is how will they impact the cost of transplantation? We're all going to need to know that. So I think you might say that the jury is out on many of these issues, but actually, I would personally say that the trial has not yet begun. I stand here today hopeful that these new tools are going to help improve outcomes. We don't know that, but if they do, I think that is certainly something that we will all have to celebrate. And with that in mind, I will just stop here and thank you.
Thank you, Michelle. The next presentation is by Dr. Bonnie Lons, Assistant Professor of Surgery from NYU Langone Transplant Institute, discussing a very important topic in transplant, which is antibody-mediated rejection. Thank you.
Excellent. All right. Thank you. Well, I'm relatively new to New York. I've been at NYU for about a year, so it's an absolute privilege to be here and talking about something that I have great clinical and research interest in, which is antibody-mediated rejection. And in terms of disclosures, I don't have any financial conflicts of interest to disclose, but basically everything I'm going to be talking about in terms of therapeutics is an off-label use of those agents. So this story starts back about 50 years ago, and this is an image from a paper published in the New England Journal by Mel Williams, who was a colleague back at Hopkins. And this is an image of what he termed at that time hyperacute kidney rejection, which was very similar to what had been observed in the first ABO incompatible transplants in the years prior to that. And fast forward a half a century, I'm showing the same picture here in as per the Banff Working Group definitions of antibody-mediated rejection, and this is something that we now recognize to be more of a continuum as opposed to an all-out onslaught on the allograft. And so the Banff Working Group has outlined the diagnostic criteria for antibody-mediated rejection, and they update these criteria every couple of years. And so just for purpose of review, we'll go through some of these because it helps us understand the therapeutics that have been developed in the intervening 50 years since this pathology has begun to be understood. So in order to meet criteria for an antibody-mediated rejection, there is a requirement for 3 different lines of evidence. So morphologic evidence on a biopsy. So this is in the form of peritubular capillaritis or glomerulitis, and here's an example of that with a neutrophilic infiltrate in the peritubular capillaries. This can also be observed in the glomerular capillaries. The inflammatory cell infiltrate can be neutrophilic, it can be mononuclear cells. In more severe cases, you can see arterial thrombi, a TMA type picture, even fibrinoid necrosis in the arterioles. The second line of evidence must include some documentation that antibodies are what is causing the problem. So C4D immunostaining is usually the test of choice. We'll talk about that a little bit more in a bit, but acknowledging that there are C4D independent flavors of antibody-mediated rejection, there can be other lines of evidence that include immunoglobulin deposition or other complement product deposition on the biopsies. And finally, of course, there must be some serologic evidence that there's donor-specific antibody circulating in the recipient, which is causing the underlying problem. When it comes to chronic active antibody-mediated rejection, it is really just as the name implies. This is sort of a low-level, smoldering antibody-mediated injury that comes with it, this chronic inflammation and imparts chronic injury. And so morphologically, histologically, it's a similar picture to the acute AMR, but you start to see evidence of chronic change. And unfortunately, once this sort of pathology sets in, a lot of these changes end up being irreversible. But again, there are 3 lines of evidence that are required in order to make a diagnosis of chronic active AMR. Morphological evidence, and in this case, what's demonstrated here, is thickening of the basement membranes within the glomerular capillaries. And on electron microscopy, this is demonstrated as multilamination of the capillary basement membranes. And when this becomes very severe, what you see on light microscopy is duplication of the capillary basement membranes. Secondly, again, you have to have evidence of immunohistologic evidence that antibodies are the underlying cause of the pathology. So, for instance, linear C4D in the peritubular capillaries, or at least moderate multivascular inflammation in terms of the G and the PTC scores. And of course, there has to be serological evidence that there is circulating anti-donor antibody within the recipient. Skipped ahead here. So the histopathology is all brought into context in the setting of what we now understand the mechanisms of antibody-mediated rejection to be. And this is a slide that's stolen from a nice review written by Mark Stegall, who's a leader in the field. And as we understand it now, antibody-mediated rejection in most cases occurs when HLA-specific antibody recognizes its HLA molecules typically expressed on the vascular endothelium. In most cases, the antibodies are then bound by complement, and this initiates the whole cascade of complement that has several downstream effects. And in terms of the therapeutic interventions, they are all aimed at targeting one point in this process or another. So just kind of walking through the cascade of events, the proximal complement components include a cleavage of the C4 complement protein, which has a split product known as C4d, which is convenient diagnostically, not so well understood in terms of its clinical significance, but needless to say, it covalently binds where it's cleaved on the vascular endothelium and is kind of a robust marker that that initial part of the complement cascade has been triggered. The additional C3 split products then trigger further downstream points in the complement cascade, and ultimately the complement cascade culminates in the formation of what's called the membrane attack complex, which is a complex of a C5 split product with C6 through C9, and the C5b plus C6 through C9 forms the membrane attack complex. This is basically the effector molecule of the complement cascade, which actually imparts the injury on the endothelial cells. And along the way, the various complement split products serve as chemotactic agents that recruit other inflammatory cells, the mononuclear cells, the polymorphonuclear sites. All of these sort of generate a pro-inflammatory environment that can have other effects in terms of activating the platelet cascade. And as you can start to imagine, that this whole cascade of events, when left unchecked, can lead to a pretty significant catastrophe at the level of the tissues. And so if there's one message that I would leave you with, it's that leaving this whole process unchecked is probably the most unfavorable situation. And so in terms of rescuing kidneys from antibody-mediated rejection, really what's most important is suspecting it early, proving that that's what's going on, and establishing the diagnosis, and then initiating treatment as early as you can before some of these injuries turn into processes that are irreversible. And so who do you need to keep in the back of your mind is at the highest risk? Well, it goes without saying that anyone who has known donor-specific antibody or historical donor-specific antibody, these are going to be your incompatible transplant recipients. Anybody who's highly sensitized, whether they have donor-specific antibody that you know of or not, these people are at particularly high risk. Anyone who reduces their immunosuppression, either at their own discretion or at our direction because of infections or what have you, are at risk. Anyone who develops de novo donor-specific antibody, and these are going to be the people who have reduced or stopped their immunosuppression, who are at greatest risk to have that happen. And then anyone who has had any sort of pro-inflammatory event, such as a cellular rejection or an infection or a traumatic event or a surgical procedure, basically any of the first four groups of patients who has a pro-inflammatory event is at risk or needs to be considered to be at risk to have developed new antibodies or an exacerbation of pre-existing antibodies. And we have learned a lot from doing incompatible transplants in terms of how we stratify risk and who we recognize is at highest risk. And this is a national data set of registry of incompatible transplant recipients. And what we've seen from both single-center data and national data is that the risks for accelerated long-term graft failure are increasing in a stepwise fashion as the incompatibility increases. So those who have the most favorable starting cross-match have the best long-term outcomes, and those who have the most incompatible starting cross-match have the worst long-term outcomes. And it's not clearly shown in this data, but it kind of stands to reason that the reason for this are because the patients who have the less favorable starting cross-matches are at greatest risk to have antibody-mediated rejection. In a similar line, patients who have de novo donor-specific antibody, patients who develop de novo donor-specific antibody, have poorer long-term outcomes. And again, this is because, not unexpectedly, these are patients who are at greater risk to have antibody-mediated rejection, and along with antibody-mediated rejection comes worse long-term survival. So in terms of treatment of acute antibody-mediated rejection and chronic active antibody-mediated rejection, there really are two goals of therapy. So in acute AMR, the priorities really are in this order. First and foremost, to remove or reduce the donor-specific antibody in as much as possible, and then as a second line, to make some intervention that helps protect the tissues while the antibodies are still circulating. For chronic active AMR, the priorities are almost reversed because, somewhat by definition, you've failed to be able to remove the donor-specific antibody. You have a persistent circulation of DSA that causes problems, and so probably the most bang for the buck in terms of intervention and protecting the longevity of the graft would be to implement some sort of intervention that protects at a tissue level, in addition to whatever efforts are feasible to try to continue to remove or reduce donor-specific antibody. So what is all in the armamentarium? In terms of reducing or removing donor-specific antibody, plasmapheresis is usually the first therapy that most centers would go to. This is generally considered to be the standard of care in terms of the primary intervention when you have a diagnosis of acute antibody-mediated rejection. And to that are various adjunctive therapies that are B-cell targeted, i.e. targeting the cells that eventually become plasma cells that produce the antibody, such as rituximab, which is an anti-CD20 antibody, which targets a pre-plasma cell B-cell population, splenectomy, either surgical splenectomy or functional splenectomy by way of splenic artery embolization. Sorry. There we go. Sorry about that. Of course, the anti-plasma cell therapies such as Velcade, which are pretty attractive mechanistically because they actually inhibit the antibody-producing cells themselves. In terms of tissue protective interventions, the complement inhibitors are really the newest group of therapeutics on the scene. And eculizumab, which was probably the first agent that was used in transplant recipients, is a terminal complement inhibitor, which is a monoclonal antibody directed against the C5 complement component and prevents the cleavage of C5 into C5a and C5b, therefore prevents the formation of the MAC complex. And then there are newer classes, newer onto the transplant scene, all approved for other indications, but are more proximal complement inhibitors, and these include Cinryze and Berinert. These are two different preparations of what is an endogenous human protein, the C1 esterase inhibitor. These are prepared from human plasma. And then in addition, you have to consider other factors, such as what to do with steroids and what to do with the calcineurin inhibitors in the setting of an acute rejection. And add to that the fact that oftentimes rejections are of a mixed picture where you have cellular rejections on top of acute antibody-mediated rejections. And really what drives what combination of therapy you choose is how severely threatened the graft is. That's in theory, at least. In practice, what drives this in most cases is the fact that a lot of these therapies are off-label, incredibly expensive, and are difficult to secure for your patients even when they're needed. So in terms of plasmapheresis, again, sort of the first line therapy for after you've made a diagnosis of acute antibody-mediated rejection, our protocol is generally, as is outlined here, a single volume plasma exchange followed by a low dose of IVIG, and the frequency of introducing plasmapheresis really depends on how severe the rejection episode appears to be. So for a severe acute oliguric AMR episode, we would initiate daily plasmapheresis, and this is typically in the setting of antibodies that are at a cytotoxic positive level. And in that case, you really have a short amount of time to get ahead of the game before you start running into problems that become irreversible. So when the urine output's dropping, the creatinine's climbing, and this is happening very quickly, daily plasmapheresis until the situation is under control is usually how you have to start. For more mild antibody-mediated rejections, where maybe there's a mild elevation in creatinine, but the urine output is stable, you can be a little bit less aggressive from the outset and initiate plasmapheresis on an every other day basis until you get this situation under control. Rituximab is probably the most utilized adjunct in terms of a B-cell therapy that's added to plasmapheresis, but despite the fact that it's been used for well over a decade in these sort of clinical scenarios, there's very little data in terms of supporting its efficacy. This is a randomized controlled trial of a very small number of patients that was published only last year, and this was adding rituximab to a standard of care pheresis plus steroid pulse treatment for patients who were diagnosed with acute antibody-mediated rejection. And the primary endpoint of the study was not met by the study, which was unfortunate, in part because the study was underpowered to detect the sort of difference that they were expecting. But the primary endpoint had been a significant difference in change in creatinine at 12 days after initiation of therapy, and that difference was not observed between the rituximab-treated group and the placebo-treated group. However, there was a trend toward improved outcomes in the rituximab group as opposed to the placebo group. But again, this is the sort of level of evidence that we're dealing with all these agents. It ends up very difficult to do randomized controlled trials that isolate the functionality of the adjunctive agent. Bortezomib, also known as Velcade, again, is sort of attractive mechanistically because it's of the adjuncts is the only direct plasma cell inhibitor, and there are some centers that add this as sort of their standard of care pheresis treatment as their first-line therapy for acute antibody-mediated rejection, and a typical protocol would be similar to what is described here, but again, no randomized controlled trials have ever been done to demonstrate efficacy of this agent in this scenario. This is a study that was published by Steve Woodall's group in Cincinnati, and this is basically an observational study where they utilized Velcade in addition to plasmapheresis for patients with either early or late acute antibody-mediated rejection, and followed serial biopsies and basically cataloged what happened to those recipients who received this treatment. There are no comparison groups, not even historical controls here. Basically, they are comparing the inflammation scores on biopsies for patients who received Velcade in addition to plasmapheresis. And what this showed was that there was some improvement in the acute inflammation scores according to the Banff criteria in this group of 55 patients who had acute antibody-mediated rejection. We started using Velcade in patients who had developed severe acute oliguric AMR as sort of an added rescue therapy, because you get to a situation where if things get any worse, you're going to lose the graft. And we started adding Velcade onto our standard of care therapy, and we found mixed results. This is one specific patient who developed an acute antibody-mediated rejection sometime after transplant, but had primarily class 2 donor-specific antibody that did respond to plasmapheresis, but didn't respond to Velcade therapy, and that was different to how we had observed this drug to behave in other patients. And so subsequent studies to that demonstrated that for whatever reason, Velcade seems to be less effective at reducing class 2 antibody than it did class 1 antibody, and mechanistically, I can't explain that. But again, it speaks to the fact that all of these agents have been used sort of empirically, and in many cases on a case-by-case basis, and that's what we're using to guide our therapies. So eculizumab was the first complement inhibitor that was utilized for acute antibody-mediated rejection, and mechanistically this also made sense. It's sort of in the sense that this agent could protect at the level of the tissue injury while the antibody was being cleared by some other process like pheresis. And so this is the first case report of eculizumab, which was used in the setting of antibody-mediated rejection. And this was a patient who had a positive cross-match living donor kidney transplant and experienced a accelerated antibody-mediated rejection at about a week post-transplant with acute oliguria, acute rise in high titer donor-specific antibodies, and in addition to daily plasmapheresis, eculizumab was added, and ultimately the pheresis kind of caught up, the antibody strengths decreased, and the urine output recovered for this patient. And this is a retrospective study from Hopkins looking at the patients in whom eculizumab was added or added in conjunction with splenectomy compared to splenectomy alone, which prior to eculizumab had been really the only rescue maneuver for severe acute rejections. And this is a bit of a busy slide, but basically, there are three sets of three columns here. On the leftmost three columns are a small number of patients who received splenectomy alone. And again, this is in addition to plasmapheresis. So splenectomy alone on the left three, eculizumab alone in the middle three, and splenectomy plus eculizumab on the far right three. And I guess the most important points are that the black shading represents a graft loss, and the blue shading represents zero chronicity scores on biopsies. So in the patients who received splenectomy alone or eculizumab alone, there were graft losses that were significant within the first year. And for the patients who received splenectomy in addition to eculizumab, not only were there no graft losses, but the chronicity scores were much more favorable on 6 months and 1 month post-AMR diagnosis biopsies. But again, we're talking about very small numbers of 14 patients in the splenectomy alone and 5 and 5 in the splenectomy plus eculizumab alone. So a lot of anecdotal evidence here. The more proximal complement inhibitors are sort of newer on the scene, and there are now starting to be some clinical trials that are either recently published or are underway using these agents. They are a bit more attractive because not only do they block complement at its most upstream state, so the chemotactic agents that are the various complement split products that are produced as a consequence of acting the cascade are theoretically all blocked by these sorts of inhibitors, whereas they're not by the terminal complement inhibitors. But they also have some efficacy in the general coagulation cascade and may have some benefit in terms of minimizing risks of thrombotic microangiopathy. So these, again, are FDA approved for indications outside of transplantation, certainly outside of antibody-mediated rejection. This is the only randomized controlled trial thus far using a complement inhibitor in patients with antibody-mediated rejection after transplant. And again, we're talking about very small numbers of patients. It was 18 patients total in the study, and these were patients who developed acute antibody-mediated rejection, and in addition to plasmapheresis and other standard of care therapy, were randomized either to receive placebo or C1 esterase inhibitor. And there were no significant differences noted in terms of improvement in creatinine, probably in large part due to the small sample size, but probably the most important finding out of this study was that the patients who received placebo were significantly at greater risk to have developed transplant glomerulopathy 6 months after the diagnosis of antibody-mediated rejection. And again, a little bit of a not so easy to follow slide, but the purple bars represent endogenously measured C1 esterase. And so the group that received Cinryze had supplemented endogenous C1 esterase. The placebo group, some of those patients had their own endogenous C1 esterase. Those who had the lowest levels of C1 esterase measurable in their bloodstream were the patients who went on to develop early transplant glomerulopathy. So a promising agent, but again, you're talking about trials with very small numbers of patients. But just to illustrate sort of what we are capable of with these various interventions, I just want to talk about a recent case. This is a patient who's highly sensitized, had a PRA of 100% from pregnancies and transfusions, had no prior transplants, underwent a kidney transplant, and at about 7 days post-op, developed a severe antibody-mediated rejection. It was a deceased donor transplant, so the diagnosis might have been delayed a little bit by the fact that there was some delayed graft function. But by the time the biopsy was done, this is what it looked like. So the glomeruli aren't really well shown here, but there was diffuse TMA, there was diffuse small vessel thrombosis, and fibrinoid necrosis with actually hemorrhagic infarction of a lot of the cortex, in addition to this background of dense inflammatory cell infiltrate. But we were 7 days into the transplant, so this patient got everything: IVIG, rituximab, Velcade, eculizumab, daily pheresis, a splenic embolization, and this aggressive therapy went on for about 2 weeks, and eventually so in the blue line here, we see the cytotoxic level antibodies. This actually woefully underestimates the MFI. The 25,000 MFI was seen at a dilution of 1 to 64 on about post-op day 10 for this patient. So very, very high level class 1 antibodies in this patient. But ultimately, with that therapy, the urine output increased, and the patient's creatinine, which is illustrated in the yellow line here, decreased. And right now, the biopsy on the left was the at-diagnosis biopsy, and the biopsy on the right was done in about a month after this therapy. And what you can see here are some relatively healthy glomeruli. There's certainly some interstitial fibrosis here, which probably won't go away, but most of the acute inflammation has resolved, and the patient right now has a creatinine of 1.7, and hopefully that will last the patient a long time. And so this case sort of speaks to the fact that the earlier you intervene, the better off you are in terms of your chances of being able to reverse what can be very dramatic processes. And this study sort of speaks to that point. This is a retrospective analysis of patients who developed either clinical or subclinical antibody-mediated rejection compared to matched controls who didn't develop a clinical or a subclinical antibody-mediated rejection. And this is graft loss as opposed to graft survival. But those who develop the antibody-mediated rejection, either clinical or subclinical, do worse than those who don't. For patients who go on to develop this chronic acute antibody-mediated rejection with donor-specific antibodies that are impossible to clear, basically making that diagnosis, the clock is more or less ticking on these grafts. And once that diagnosis is made, this is a study from the University of Wisconsin, the median survival is less than 2 years for the allografts. Okay, we're back. All right, and again, from the same group at Wisconsin, while the standard of care therapies for chronic acute antibody-mediated rejection or chronic antibody-mediated rejection aren't well established, what is clear is that it does seem to be better to do something than to do nothing. And this is sort of an active area of investigation because there's a tremendous unmet need in transplantation for therapies that can help sort of protect and preserve grafts when there has been the development of some amount of antibody. So there's probably going to be a role here for the complement inhibitors, and this is a study that was published by a French group a year ago in AJT, and there are some placebo-controlled trials that are just getting off the ground now to try to study this agent in this indication. It was an open-label, single-arm trial where the C1 esterase inhibitor was given to patients who basically failed standard of care therapy. So these were patients who had a diagnosis of antibody-mediated rejection and underwent 3 months of standard of care therapy with plasmapheresis, rituximab, IVIG without any sort of improvement. And at that point, were given C1 esterase inhibitor for a period of 6 months. And these are compared to historical controls, so there are no controls built into this study. But basically the teal lines here, they show up green up there. The green bars are the patients who received the C1 esterase inhibitor, and the red bars are the historical controls. And 6 patients total were treated, and among those 6, all of them had some improvement in GFR after this therapy, and the historical controls, it was only a small fraction of them. Most of them continued to have deteriorating graft function. This is another agent that has sort of recently come onto the scene in terms of possibly a novel therapy for chronic antibody-mediated rejection. This is an anti-IL-6 receptor monoclonal antibody, so an IL-6 receptor antagonist called Socialism AB, and this is a study published by Stan Jordan's group earlier this year in AJT. The thought process here is that IL-6 is a cytokine that is involved in activation of T cells, B cells, plasma cells, and in that way may serve some sort of protective effect in the absence of not being able to clear the primary problem, which is the antibodies. And so these were patients who had chronic active antibody-mediated rejection plus or minus transplant glomerulopathy on biopsies who had failed other therapies. And in this case, that was high-dose IVIG or rituximab plus or minus plasmapheresis. And these patients, this was again an open-label, single-arm trial. These are patients that were treated with tocilizumab with monthly infusions for a minimum of 6 months to a maximum of 25 months. And in this case, they were able to demonstrate that for the patients that were treated, the outcomes were far better than would be predicted for patients who otherwise had a diagnosis of chronic antibody-mediated rejection or transplant glomerulopathy. So the 6-year predicted graft survival probability was on the order of 80%, which is far better than what has otherwise been demonstrated for this patient population. And so what I think is up and coming and what we have to look forward to, some of which was alluded to in the prior talk, is we're getting better at diagnosing antibody-mediated rejection more accurately, earlier, less invasively. So we have better and more specific diagnostic tools using metabolomics, proteomics, cell-free donor-derived DNA techniques, urine markers, again, less invasive techniques to help us figure out who's at risk for rejection and how we can start picking it up sooner. And there also will be new exciting agents that come onto the scene. And I like this topic because if I had given this talk a year ago, I wouldn't be talking about half of these things. And if I were to give this talk in a year, there would be new agents that we would be talking about that are exciting. And this is probably the most exciting among them. This drug called IDIS, which is an enzyme which is derived from a bacterium, and it has the property in that it specifically cleaves human and rabbit IgG, and basically splits the antibody into FAB and FC fragments, rendering it completely inactive and unable to bind complement. And it's very potent. So these are individual HLA antibodies with their corresponding MFI values in a highly sensitized patient. Each bar represents a different HLA antibody specificity, and the red bars are serum from the patient before IDIS treatment, and the blue bars are serum from the patient 6 hours after IDIS treatment. And so very efficiently, this molecule cleaves all of the circulating IgG, and this is currently being trialed, was recently reported again by Stan Jordan, in desensitization protocols in order to enable transplantation for patients who have high level of antibody and don't have a living donor or do have a living donor. But it's not easy, it's not difficult to imagine that this will have great efficacy in the situations of severe acute antibody-mediated rejection as well. So this is what we have to look forward to. And I'll stop there and just take a minute to acknowledge our team at NYU. Thank you.
The next speaker is our own Dr. Brendan Alderson. He's our transplant ID specialist, very much involved in transplant, and he'll be talking about what is dubbed as the most common infection after transplant, UTIs.
Yeah. Hello, so my name is Brendan Eilertson. I'm here at Downstate. I generally do antimicrobial resistance research, interest in the renal population. So what I'm going to talk today about is urinary tract infection in the transplant population. So unlike the previous talks, this is not a hot research area. It is a bit of a backwater. And the issue too is that, as the previous researchers have said, there's relatively small populations here. So most of the research in this field is going to be from large national data collection tools and studies based on that. So remember to advance these together. So I'm going to use an analogy of weeds here. So weeds are generally species that if you saw them in one place where they belong naturally, you'd say, okay, fine, whatever. So if this is someone's lawn, you'd say, okay, those plants should be there, but this is what one would expect to be a relatively sterile office environment, so that's a little amiss. So I like this analogy of weeds because antibiotic-resistant bacteria are survivors, and they're constantly changing. So I found a couple quotes that I liked. One is from an ecologist, actually, who said, "But make no mistake, the weeds will win, nature bats last." And I think that's an important thing to remember, that I have job security and that I have many species actively evolving to make sure that I will always have something to do. And similarly, a timely quote from Richard III, which, see it at BAM if you can, it's amazing. "Sweet flowers are slow and weeds make haste." So these are also species that tend to grow quickly. So the goals today are basically to kind of give you a survey of this topic. So first of all, to understand some of the risk factors for developing UTIs, particularly in the early post-transplant period, to appreciate the impact of these infections on patient outcomes and renal allograft function. Also to describe the epidemiology of these bacteria and other organisms, so basically what's causing UTIs in this population. Then very importantly for me as an ID consultant is a rationale for diagnosing UTI, so when does someone actually have a UTI? Then also discussing a choice of empiric therapy and a duration of treatment, and plus if there's any need for urologic or surgical intervention. So I'm going to start with the epidemiology. So as I said, a lot of the data that we do have is generally from large national studies. A lot of the European countries are ahead of us in this, that they've been able to kind of mobilize their data to do a little more research on infections than I think we have in the US. So this is a study from Spain in which they looked at about 2,400 solid organ transplant recipients. And this is just to put renal transplants in perspective. This should not be a surprise for anyone here that the incidence is about 4 times higher for renal transplants than any other kind of solid organ transplant for cystitis. Pyelonephritis, again, more than 4 times greater incidence than any other type of transplant. And also an important note that there's a kind of high prevalence of associated bacteremia secondary to UTI in renal transplant patients. Heart transplants are pretty lucky, they do pretty well. Lung transplant recipients have other issues, but that's not our topic today. Sorry, I keep falling behind here. So basically, the most important thing to take away about the timing of UTI, and anyone who takes care of these patients knows that it's predominantly an early complication. So 84% in one study, this Spanish group, 84% of symptomatic UTIs occurred in the first 6 months. They also noted a UTI incidence of 26% during the first year post-transplant, with the most common immunosuppressive regimen, basically what I think is the most prevalent one nationally, of a calcineurin inhibitor, mycophenolate, and corticosteroids. So why do we care about this? So this is again a study from Spain, but from a different patient population, looking at about 800 patients. So you can see here as you follow up these patients over time, that there is a higher rate of graft loss in patients with acute graft pyelonephritis. So that's the main thing that we fear in terms of an infectious complication that can impact graft function. But even just looking at UTI in this case, 26% of these patients actually had impaired graft function. So that's including people who just had UTIs, though interestingly, and we've seen this in other populations, not just renal transplant, we find that the mortality rate for these infections are very low. So it's very rare for people to die of a UTI, even with a very resistant organism, but it definitely can affect their graft function. Moving on to definitions, this is very important to me as an ID doctor, that very often we get a call and it's, oh my gosh, this patient has bacteria growing, what antibiotics should we use? And for us, it's important to kind of decide, first of all, okay, is this an infection or not? First of all, asymptomatic bacteriuria is basically any urine culture that's growing uropathogen, but in the absence of symptoms. And in particular, it's a very key issue with women to make sure that this is truly to distinguish whether this is asymptomatic and is a asymptomatic bacteria or is a pathogen. So the definition is a little different from women than from men in asymptomatic bacteria. And a lot of these definitions come straight out of the American Journal of Transplant guidelines from 2013. So basically, in women, it's defined as 2 consecutive clean catch voided urine specimens more than 24 hours apart with isolation of the same organism, more than 100,000 CFU per ml. In men, because of the structural differences in the urethra, a single clean catch voided urine specimen with isolation greater than 100,000. Bacteriuria is also defined as isolation of a single organism more than 100 colony-forming units per ml if this has been a catheterized patient where they've basically done an in and out cath to get a clean specimen. So then you say symptomatic urinary tract infection. So this is kind of your classic symptoms, things that I think are widely accepted as easy to determine symptoms. So people have dysuria, frequency, urgency, suprapubic pain. Similarly, obviously, in a renal allograft recipient, they can have pain and tenderness over the graft, CVA tenderness certainly suggesting of upper urinary tract involvement. But also keeping in mind that some of these patients may present with fever, malaise, something nonspecific that may not localize to the urinary tract. Recurrent UTI is when you have 3 or more episodes of symptomatic UTI over a year. So it can also be 2 episodes in 6 months, and that should be distinguished from a relapsed UTI, which is where you have a very prompt recurrence of the same organism following treatment. So then a complicated UTI is when you have an infection associated with structural or functional abnormalities of the GU tract, or more importantly in this population, you have presence of an underlying disease that increases the risk for acquiring an infection or of failing therapy. So symptomatic UTI in any renal transplant recipient is by definition considered complicated. So that's whether it involves the lower tract, the upper tract. So that's an important thing to remember. So then if we talk about risk factors, so specific to the transplant population, this is a table out of the American Journal of Transplant guidelines. So basically this is looking at these risk factors. So, I think what should stand out most is that the strongest risk factor based on the odds ratio is actually the immunosuppression. So if you increase immune suppression, that is far and away the thing most likely to increase the risk of UTI. So other things, of course, because of structural differences, female gender is an increased risk. Deceased donor transplant is also a risk, just related to kind of the time it takes to kind of transport that organ, that inevitably there will be some bacteria that can get into the graft. I won't go into Candida era at all. In terms of acute pyelonephritis, just of note, similarly, female gender, acute transplant rejection, just because, again, you're likely to be doing higher levels of immunosuppression when you have rejection episodes. Yeah, so this is just to give you the image for what I was talking about. So again, it was an increase in immunosuppression being the kind of the strongest risk factor for bacterial UTI, followed by female gender and deceased donor origin for the graft. You have a higher risk of UTI specifically with azathioprine or mycophenolate-based immune suppressive regimens, induction therapy with cell-depleting antibodies such as antithymocyte globulin have been reported to have a higher incidence of UTI, and then late infection, which is defined as more than 6 months after transplant, is associated with prednisone doses greater than 20 milligrams PO daily, having therapy for multiple rejections, and chronic viral infections. So if someone has an active CMV infection, that can also have an impact. So also there's a role for prolonged instrumentation or catheterization. That's an important risk factor in and of itself. So in Fayek et al., they reported basically a higher UTI rate in kidney transplants with stents compared to a lower rate in patients without stents, though it did reduce ureteral complications. Prolonged stent placement greater than 30 days also increased UTI risk significantly. So moving along to the microbiology. So this is, again, kind of what I think most of you guys see in your clinical practice. So you can see that far and away, the biggest group responsible for urinary tract infections are going to be gram-negative organisms, specifically the Enterobacteriaceae. So E. coli being the species that is responsible for the most, about 35% of cases in the sample, followed by Enterococcus, Pseudomonas. Klebsiella is further down the list than I would say we see here clinically. This was kind of the best study I was able to see in terms of numbers showing incidence of specific organisms. So ESBL organisms are certainly a particular worry for us. In ESBL organisms, you're most likely to see ESBL and Klebsiella as the species that are most associated with resistance. In patients who receive Bactrim prophylaxis or trimethoprim sulfamethoxazole, 62% of the UTI pathogens are resistant. Obviously, you expose bacteria to any antimicrobial over time, you'll select for resistant organisms. So fluoroquinolone prophylaxis has also been linked to similarly surges in fluoroquinolone-resistant Pseudomonas and other organisms. In patients with an asymptomatic E. coli or E. faecalis bacteriuria, treatment led to the selection of resistant organisms in 78% of treated patients. So that's something we'll come back to about the role of prophylaxis, specifically involving UTIs, that you are generally going to produce resistant organisms if you do that. So again, in the Recitra cohort study that I've mentioned a couple times from Spain, of their 118 cases of symptomatic E. coli UTI, 26% of those were ESBL producers. In our hospital, I think kind of all comers, our E. coli is something around 20%, 16 to 20% ESBL E. coli producers. And in Brazil, isolation of ESBL producing organisms increased from 13% in first episodes of infection to 45% for a patient with a third episode of UTI. So that's, again, that same concept that the more you are exposing these patients to antibiotics, the more likely that you will have to deal with a resistant organism. So specific to Klebsiella, there was a study from Poland in which 24 of 335 transplant recipients had a total of 59 episodes of Klebsiella UTI. Of these, more than half were caused by ESBL producers. And they also specifically noted that certain organism virulence factors resulted in upper UTIs. So this is basically, the figure here is looking at a proportion of the ESBL positive strains according to the type of UTI. So you can see that really the ESBL producers were somewhat more common as you kind of got to kind of more invasive levels of urinary tract infections. So they made up higher proportion of acute pyelonephritis and urosepsis than they did asymptomatic bacteria. So carbapenem-resistant organisms are something that we've had to deal with a lot in New York. Other parts of the country, not at all. Other parts of the world, it's even more common than in the United States. So because we have relatively few infections with these organisms in other parts of the United States, this is pretty poorly studied in the US. So the studies in the US are very small. This, again, is a study, I believe this one is from Brazil, actually. So obviously, of more resistant organisms, this does correlate to a higher mortality rate. However, in this study, there was no connection between carbapenem resistance and graft loss, and again, no increased risk of death. But again, this was a small study. They looked actually both at skin and soft tissue infections and UTI, but for our purposes of these 25 patients with UTI, 100% were cured, actually. And a relatively small number went on to have recurrence, which is at least reassuring. So I'll just say a word on candidiaria. So most of the time in infectious disease, we say, oh, candida, we don't worry about that. But in allograft recipients, particularly in the post-transplant period, we do worry about that because these patients have recently been instrumented. So in one series, this is fairly common, 11% of renal transplant recipient patients. It is, however, usually asymptomatic. And there's really no way that we know of to distinguish infection from colonization. So even if somebody has pyuria and do have more than 100,000 yeast per ml, CFUs of the yeast per ml, it's not really conclusive to say whether that's an infection or not. Obviously, what we fear with Candida is that there will be a risk of ascending infection, candidemia in the blood, and obstructing fungal balls at the ureterovesicular junction. So to continue on to the pathophysiology, so when do we treat? So I think this is probably the most prevalent research question that people have for this whole topic, I would say, is looking at asymptomatic bacteriuria in the transplant population. The best evidence seems to be that the first month, asymptomatic bacteriuria is reasonable to treat. After that, the data gets progressively worse to suggest that there is a benefit in treating those patients. Symptomatic infection, obviously, we will treat, and we treat that as a complicated UTI because, as we said, being immunocompromised in the setting of renal transplant is in and of itself a reason to call a UTI complicated. Acute transplant pyelonephritis, again, is most important to treat because of the correlation with both short and sometimes long-term allograft dysfunction. But in most studies, there's not good evidence that after 5 years that there's a difference in graft survival. So this is just a word on sample collection, just to remember wherever, I'm not sure of the breakdown of this audience, if we have, if it's all physicians here or we have nurses here, or if anyone here is forced to collect a urine sample. But just knowing that pretty much everything that we do to treat these infections depends on the urine culture. So this, again, just to reiterate, the technique is important. We need antiseptic wipes to clean the perineal area, glands of the penis, collect midstream urine samples in a sterile container. Straight cath can be considered as an alternative, but clearly more invasive. If patients have indwelling catheters, particularly in place for longer than a couple weeks, those are generally going to be colonized already with organisms, so whatever urine you obtain out of that will almost certainly grow greater than 100,000 CFUs per ml of bacteria. So the recommendation right now is actually to remove the catheter and then collect either a midstream urine if the patient is able to void, or replace the catheter if it's still needed and actually get a urine sample from the new catheter. So in terms of screening for UTI, there's really no recommendation to be made for screening or for treatment, just because there hasn't been a lot of good evidence on some of this. So essentially, if there is going to be screening for UTI, this is again stressing that the first month is when you have the most justification for that, and that after the first month, there's really not good evidence for that, and it's more likely that you'll be over-treating the patient with antibiotics, potentially producing more resistant organisms. For women found to have bacteriuria, a second sample may be appropriate to document continued presence of the bacteriuria. And as I said, basically the main adverse effect of screening beyond the first month is overexposure to antibiotics and selecting for resistant organisms. So diagnosis of symptomatic UTI, again, as I've said, quantitative count of more than 100,000 CFU per ml in an appropriately collected urine specimen is kind of our main thing that we're looking for microbiologically. But it also should be a uropathogen. So there are some organisms, Lactobacillus gardnerella, that we would not expect to be a pathogen. Also, urine cultures with multiple pathogens certainly would suggest that it's contamination. Pyuria, so defined as greater than 10 WBCs per high-powered field, does not necessarily confirm UTI, but if someone has an infection, it's very unlikely for them to be less than, to lack 10 white blood cells per high-powered field, unless the patient is profoundly immune suppressed. So imaging with renal ultrasound or non-contrast CT should also be considered to assess for obstruction or abscess if the patient is not doing well despite initial therapy. Then in terms of treatment, so we're treating these cases. What do we want to use? Basically, this is to describe one study of 334 cases of asymptomatic E. coli or E. faecalis bacteriuria identified a month after renal transplant. Evolution to symptomatic UTI was similar between the treated and the untreated groups. So this is one of the studies that suggests that we may be better off not treating these people, that if only maybe 1.5% of these people who were untreated in the setting of asymptomatic bacteria went on to develop infection, that may not be worth the adverse effects of selecting for resistant pathogens, which they note occurred in 78% of cases. 112 patients with asymptomatic bacteriuria randomized at 2 months to treat asymptomatic bacteria with 3 to 7 days of antibiotic or no treatment, similarly had no difference in rates of acute pyelonephritis or UTI at 2 years. So again, looking at a study where the patients were all treated in the first 2 months for asymptomatic bacteria, but then randomized at 2 months, there was no benefit when you look at 2 years to treating those patients for asymptomatic bacteriuria. So then you have symptomatic UTI. So the empiric treatment, first and foremost, should include removal of any kind of urinary tract instrumentation, so catheters. If the patient still has a stent, if it's reasonable to take it out, that may help clear the infection faster. Outpatient therapies, we obviously use the heck out of fluoroquinolones, amoxicillin clopulinate, certainly, oral third-generation cephalosporins. Beta-lactams, such as cefepime or piptazo, are what we generally would use inpatient. Patients with severe infections, empiric antibiotics should take into account the patient's history. As I said, once these patients have had 2 or 3 infections, it's very likely that they will have a resistant organism. And this being New York City, we have a very high rate of ESBL prevalence. So empiric therapy in a patient that's severely ill should treat for ESBL producers. So it may be worth considering, as much as I hate to say it, as a ID doctor who specialized in resistance, it may make sense to use a carbapenem if someone is very sick in an area of high ESBL prevalence. So then definitive treatment. So once you have susceptibilities, we obviously like to choose the narrowest spectrum agent. So some people do distinguish that even though we're calling this complicated UTI, that if it is mild and the patient is looking generally well, that we can still do a short course of treatment of 5 to 7 days. And others recommend that if the UTI occurs early, post-transplant, in the first 6 months, that even mild cases should be treated 7 to 10 days. So I think the jury is still out on how long exactly we want to be treating these patients. Not surprisingly, when someone has graft pyelonephritis, urosepsis, those patients are generally to be treated longer. Again, we don't have good evidence to say how long, but we typically will recommend 14 days. Progression of upper urinary tract disease to a renal or perinephric abscess or emphysematous disease requires generally some level of intervention, either surgically or by interventional radiology. So that's just, again, a consideration when these patients aren't doing well. So then, in terms of recurrent UTI, so one observational cross-sectional study of 154 patients, they had a total of 315 episodes of post-transplant UTI, so 28.6% of the patients had UTIs. I believe this was in the first year. And most recurrent UTIs occurred during that first year. That's when these patients are most immune suppressed and they're most likely to have these infections. So the most common pathogen in recurrent UTI was Klebsiella, comprising a little over half of those cases, and were very likely to be multi-drug resistant. So there is an odds ratio of 13 for multi-drug resistance when they looked at the individual variables that predicted kind of these infections. So the presence of nosocomial infection and multi-drug resistant bacteria are also independent predictors of recurrent UTI. So basically, if a patient is in the hospital when they develop the infection, or they already have a multi-drug resistant bacteria, you're more likely to have another multi-drug resistant bacteria. And similarly, when patients have recurrent UTI, it's always important to consider whether there could be some sort of anatomic or functional abnormalities. So these are things that may need to be corrected. And also similarly, there are some people that have recommended treatment of a relapsed symptomatic UTI with prolonged antibiotic therapy, but I wouldn't recommend that right now. That I think my argument is that there should be a nidus of infection. This was just something that I thought of when I was trying to think of what you're dealing with a renal graft. I mean, this is a bridge that I think they were proposing to build in Singapore, between Singapore and Malaysia. Malaysia didn't want to tear down its half of the bridge, the old bridge. Singapore wanted to build a new bridge, and this is how they tried to put them together. So this is kind of what kind of our intrepid transplant surgeons are dealing with. You're basically putting together two things that don't really belong together. And that when you do that anastomosis, there are going to be this healing time involved. And similarly, there may be some other structural issues with the new graft or the way urine flows, and also with the native kidneys still being there, which they are very often still in the patient. So this was, again, out of the transplant guidelines from 2013, just kind of recommending a way of thinking about this from a structural, kind of urologic perspective. So mostly the key things we're talking about here are looking at imaging, considering prostatitis, as that's often missed, and then also checking for a post-void residual, and essentially looking to see if there is something that could be corrected surgically or not. And I think I have just about a minute left, so I'll just say a word on prevention of UTI. So not surprisingly, we obviously want to treat any existing infections, correct any structural abnormalities that can be fixed before transplant. Immediately post-transplant, donor-transmitted infection is possible. So if there is a patient who has deceased donor transplant, it's very important to find out if there's any culture growth from the organ preservation fluid. Similarly, these patients are all getting routine perioperative antibiotic prophylaxis before surgery, which does help reduce the risk of UTI, and obviously minimizing the use of indwelling catheters and stents as much as possible. In terms of antibiotic prophylaxis, so prophylaxis did reduce the risk of developing sepsis with bacteremia by 87%. The risk for developing bacteriuria was reduced by 60%. However, this prophylaxis had no effect on all-cause mortality or graft outcome. We use very often trimethoprim sulfamethoxazole for other reasons, but in terms of reducing the risk of infections, the higher dose, the double strength versus a single strength, was more effective. However, the prophylaxis is less likely than maybe other agents to prevent UTI. So trimethoprim sulfamethoxazole might not be the best thing if we were trying to prophylax UTIs, but it's used clearly for other reasons too. And also of note, we don't recommend fluoroquinolones because fluoroquinolones literally are a 1-point mutation away from developing resistance in all of these pathogens. And I think that's pretty much everything. So I mean, the summary here is that beyond the first 1 to 2 months post-transplant, there's no evidence to support treating asymptomatic bacteriuria. Antibiotic exposure to treat asymptomatic bacteria, prophylaxis, or to treat true infection, whatever you're treating, will always drive selection of antibiotic resistance, predominantly ESBL and carbapenem resistance, and just to always consider structural abnormalities. So that's it. So I guess we'll finish there as I'm being beeped off the stage and you guys want lunch.
Invite all the speakers to the podium for a 5-minute session for discussions. Any questions from the
What is
audience?
about just DSA or subclinical AMR, and what is the approach you suggest, or please comment on that?
Our practice
for Hartford.
In the presence of PSA, we perform a biopsy.
You have something to
Yeah.
That's in the presence
at
of
the
PSA
end,
normal
and
allograft.
I'll make a copy for
And
you.
in the absence of any biopsy
Okay, thank you.
findings suggesting rejection, that we will watch. Subclinical rejection could be when you treat every time. If there's any diagnostic evidence on a biopsy that there's acute inflammation, injury, that's likely to turn into a problem if not treated, so we treat that.
You had mentioned that some of your patients are C4D negative with antibody rejection. Is there any data as to how common are those rejections, and are they harder to treat as compared to the C4D positive?
It's certainly less common. I don't know if I have enough even anecdotal evidence to tell you whether I think they're easier or more difficult to treat. We treat them in the same way. By treating, in those cases, most of the time there is circulating and also by serial biopsy.
By the way, if you want, thank you to the available online so you can get the whole symposium. Yeah, I just need
Rami?
Thank you very much for the talk. This question for Dr. Erliston. Is there any data about treating asymptomatic bacteriuria right before the transplant, if it's like short period before the transplant?
I mean, the patients that are actually talk about specific to the pre-transplant period. I mean, clearly these patients will be getting kind of perioperative transplant antibiotics, and it's not clear. I don't think there's any guidance on what. I mean, obviously there's a symptomatic UTI these people would be treated, but I don't think there's specific guidance on what to do with asymptomatic.
I may have missed this because I had to run out, but for a patient who has documented recurrent UTIs, do you recommend surveillance, and if so, over what period of time? Patient with documented recurrent UTI.
I mean, I would not recommend surveillance for those patients unless they're symptomatic, because very often those patients have structural abnormalities, and sometimes we see these patients that will have, every time you look at their urine, they will have a positive urine culture. And if we treat them, we eventually do run out of therapies, particularly PO therapies. So I found that the key thing is having consultations with the urologist and seeing if there's any structural changes that can be addressed. So generally, we would not screen people with recurrent UTIs unless they're symptomatic.
They said the average lifespan for a renal transplant like 5 years. I want to know with all the new technology, has that increased? And what is the survival of renal transplant?
You're asking about the average lifespan? Yeah, I'm going to say 5 years. Yeah, I think we have longer than 5 years. For a listener, average is about 7 years.
I'm very concerned. Someone else was wondering if I could ask you a question about with all the new emerging meds for chronic or book that we're looking at for chronic antibody rejection. What has become your approach?
So I don't know, you do what you can. I think the most important thing is when you have acute cut down on the acute inflammation, really real life you're talking about early rejection. I don't know.
Dr. Josephson, has anybody done any analysis as to develop a score for the recipient? I mean, we have donor score to assess high risk and low risk. Has anybody looked into developing a risk for the recipient in terms of immune reaction and chances for rejection in order to tailor treatment?
Not to my knowledge, but I think it's a fascinating idea. Maybe as these biomarkers emerge, we will be able to, use them in some manner to look at, risk of cellular risk of antibody-mediated risk. Maybe we'll use them to sort of come up with some idea, but I think that's something I suspect we'll sort of do it informally, but maybe we will formalize something and say, you know, if you have this constellation of markers, you worry about this more, you worry about that, and this is how we should approach it. But, so there's a lot of potential out there as these things emerge, but not as of yet.
Right, any other questions? Dr. Tedla, or what time will you convene?
At 1:25.